Understanding the major structures of the respiratory system and the physiology of breathing is essential for recognizing and managing respiratory emergencies. The respiratory system is responsible for bringing oxygen into the body and removing carbon dioxide. It consists of several key structures that work together to ensure gas exchange. The nose is the primary entry point for air. It filters, warms, and moistens the air before it travels deeper into the lungs. The nasal cavity also contains cilia and mucus that trap dust, pathogens, and other particles to prevent them from entering the lungs. The pharynx is a muscular tube that connects the nasal cavity to the larynx and esophagus. It serves as a passageway for both air and food, directing air toward the larynx and food toward the esophagus. Located at the top of the trachea, the larynx contains the vocal cords and serves as a gateway between the pharynx and the trachea. It also protects the lower airways by preventing food or liquids from entering the trachea during swallowing. The trachea is a tube that extends from the larynx and branches into the bronchi. It is lined with cilia and mucus to trap and remove foreign particles. The trachea serves as the main conduit for air to enter the lungs. The trachea divides into two primary bronchi, which further branch into smaller bronchioles within the lungs. These airways distribute air to different parts of the lungs. Bronchioles eventually lead to tiny air sacs called alveoli. Alveoli are tiny, balloon-like structures where gas exchange takes place. The walls of the alveoli are thin and surrounded by a network of capillaries. Oxygen passes from the alveoli into the blood, while carbon dioxide moves from the blood into the alveoli to be exhaled. The lungs are two large, spongy organs located in the chest. They house the bronchi, bronchioles, and alveoli. The lungs expand and contract as you breathe, allowing for the exchange of gases. The diaphragm is a large, dome-shaped muscle located below the lungs. It plays a crucial role in breathing by contracting and relaxing to change the volume of the chest cavity, which facilitates air movement in and out of the lungs. Breathing is the process by which air is taken into the lungs during inhalation and expelled from the lungs during exhalation. It involves both mechanical and chemical processes to ensure proper gas exchange and regulation of oxygen and carbon dioxide levels in the body. During inhalation, the diaphragm contracts and moves downward while the intercostal muscles, the muscles between the ribs, contract, causing the rib cage to expand. This expansion increases the volume of the thoracic cavity and lowers the pressure inside the lungs, causing air to flow into the lungs through the airways. Oxygen from the inhaled air moves across the thin walls of the alveoli and enters the blood vessels through capillaries. Exhalation is primarily a passive process. As the diaphragm relaxes and moves upward and the intercostal muscles relax, the volume of the chest cavity decreases. This increases the pressure inside the lungs, forcing air out. Carbon dioxide, a waste product of cellular metabolism, is expelled from the body as it moves from the blood into the alveoli and is exhaled. In the alveoli, oxygen from the inhaled air passes through the thin alveolar walls and enters the blood. At the same time, carbon dioxide from the blood moves into the alveoli to be exhaled. This exchange of gases occurs by diffusion, where oxygen moves from an area of higher concentration, the alveoli, to an area of lower concentration, the blood, and carbon dioxide moves in the opposite direction. The respiratory rate is controlled by the brainstem, specifically the medulla oblongata and pons. These areas monitor levels of carbon dioxide in the blood, which influences the rate and depth of breathing. When carbon dioxide levels rise, the body signals the brain to increase the rate of breathing to expel the excess CO2 and restore balance. In summary, the respiratory system is made up of a series of structures including the nose, throat, trachea, bronchi, alveoli, and diaphragm, all working together to facilitate the exchange of gases. Breathing involves the mechanical processes of inhalation and exhalation regulated by the brain and controlled by the diaphragm and muscles of respiration. Proper functioning of the respiratory system is essential for delivering oxygen to the body and removing carbon dioxide, keeping the body's internal environment stable.
It's essential to understand the difference between adequate and inadequate breathing, as recognizing this distinction allows EMTs to assess and intervene appropriately in respiratory emergencies. Adequate breathing is when a person is able to breathe in enough oxygen and expel enough carbon dioxide to maintain normal blood gas levels and meet the body's metabolic demands. Key characteristics of adequate breathing include: in adults, the normal respiratory rate is typically between 12 to 20 breaths per minute. For children, the rate is faster, 20 to 30 breaths per minute, and for infants, it's even higher, 30 to 60 breaths per minute. When the person's breathing is relaxed and unlabored, the chest rises and falls symmetrically, and there's no sign of excessive effort or use of accessory muscles, such as the muscles in the neck, chest, or abdomen. The breaths are normal in depth, not too shallow and not too deep. And the person is able to take in an adequate volume of air with each breath. Breathing is generally quiet and without abnormal noises like wheezing, gurgling, or stridor. The person may be able to speak in full sentences without difficulty. The person's skin, lips, and mucous membranes should be pink and well perfused. There should be no signs of cyanosis, or bluish tint, indicating a lack of oxygen. Adequate breathing supports normal oxygen levels in the blood and the removal of carbon dioxide. Blood oxygen saturation, SpO2, should generally be around 95 to 100%. When breathing is adequate, the body is maintaining proper gas exchange, and no immediate intervention is needed beyond routine monitoring. Inadequate breathing occurs when the person is unable to move air effectively into the lungs to meet the body's oxygen demands or remove enough carbon dioxide. Inadequate breathing requires immediate intervention and can be life-threatening. Key signs of inadequate breathing include abnormal rate. Respiratory rates outside the normal range indicate potential breathing problems. Tachypnea, rapid breathing, or bradypnea, slow breathing, can be signs of respiratory distress, but may still be effective if the depth is appropriate. However, both extremes can indicate that the body is struggling to maintain oxygen levels. Use of accessory muscles. The person may be using extra muscles to breathe, such as the muscles of the neck, chest, or abdomen. This can be seen as retractions, where the skin pulls in around the ribs, clavicles, or sternum with each breath. This often indicates that the person is working harder to breathe and is not getting enough air. Shallow breathing, breathing that is too shallow, in which the chest does not rise and fall adequately with each breath, can indicate that the person is unable to ventilate properly. Shallow breathing may result from conditions like pain, fatigue, or respiratory illness. Abnormal sounds. Breathing may be accompanied by stridor, a high-pitched sound, wheezing, a whistling sound, gurgling, or snoring. These sounds can indicate obstruction, narrowing of the airways, or fluid in the airways. The person may develop cyanosis, or a blue or purple discoloration, around the lips, face, or extremities, which is a sign that there is inadequate oxygenation in the blood. Inadequate breathing leads to poor oxygenation, which can result in confusion, dizziness, or even loss of consciousness. If the brain is not receiving enough oxygen, the person's cognitive function declines rapidly. Inadequate breathing can cause abnormal patterns such as Cheyne-Stokes respiration, a cycle of rapid breathing followed by periods of no breathing, or agonal respirations, gasping, irregular breaths that are ineffective at moving air. These are signs of severe respiratory distress or impending respiratory failure. Inadequate breathing results in low blood oxygen levels, known as hypoxia, and high carbon dioxide levels, called hypercapnia, which can be life-threatening. Monitoring oxygen saturation and signs of respiratory fatigue can help identify this.
For patients with inadequate breathing, EMTs must act quickly to restore proper ventilation and oxygenation. This may involve oxygen therapy to increase oxygen levels, airway management to ensure the airway is clear, such as using airway adjuncts, nasopharyngeal or oropharyngeal airways, or intubation in severe cases. Assisted ventilation using a bag valve mask, or BVM, if the patient is not breathing adequately on their own. CPR if the patient is not breathing and has no pulse. In summary, recognizing adequate versus inadequate breathing is crucial for EMTs in managing respiratory emergencies. Adequate breathing maintains normal oxygenation and ventilation, while inadequate breathing requires prompt intervention to prevent serious complications like hypoxia, organ failure, or death.
When responding to a patient who may be experiencing apnea, it's crucial to act quickly and methodically. Apnea is the cessation of breathing, and it can result in life-threatening oxygen deprivation. Start by assessing the patient's level of consciousness. Gently tap or shake the patient and shout to see if they respond. If there's no response, immediately assess the airway to ensure it's clear. Remember, a blocked airway is one of the leading causes of apnea. To open the airway, use the head tilt, chin lift maneuver unless there's a suspected spinal injury, in which case, use a jaw thrust. Look for any obstructions, such as the tongue, foreign objects, or blood. Next, assess breathing. Look for the rise and fall of the chest, listen for breath sounds, and feel for airflow. If the patient is not breathing or shows signs of apnea, such as no chest movement or lack of airflow, immediate intervention is required. For a patient in apnea, begin assisted ventilation with a bag valve mask. Seal the mask over the patient's nose and mouth, and deliver breaths at a rate of about 10 to 12 breaths per minute. Ensure each breath is effective. You should see the chest rise with each ventilation. Administer oxygen to maintain adequate oxygenation. If the patient's airway is clear and they're not breathing on their own, you may need to consider advanced airway management, depending on the situation. Monitor the patient closely as you prepare for transport. Reassess the patient's airway and breathing frequently. Watch for signs of return of spontaneous breathing, and continue to provide supportive care as needed. Remember, in any case of apnea, rapid recognition and immediate intervention are key to preventing hypoxia and ensuring the best outcome for the patient. Always stay calm, act swiftly, and follow your protocols for airway management and respiratory support.
As an EMT, assessing a patient's respiration is crucial for determining their level of respiratory distress and deciding on the necessary interventions. The first step is to evaluate whether their breathing is adequate or inadequate, which can significantly impact your treatment decisions. Adequate respiration refers to normal breathing, where the body is receiving enough oxygen and effectively removing carbon dioxide. Here's how to assess it. Check the respiratory rate. The normal adult rate is between 12 to 20 breaths per minute. For children, it will be higher, typically between 20 to 30 breaths per minute. The patient should breathe effortlessly without using extra muscles or showing signs of distress. The chest rises and falls symmetrically with each breath. Breaths should be normal in depth, not too shallow and not too deep. Breathing should be quiet, without abnormal sounds like wheezing, stridor, or gurgling. The patient should have a healthy pink color in their skin, lips, and nails, indicating proper oxygenation. Inadequate respiration occurs when the patient's breathing is insufficient to meet their body's oxygen needs. This can be caused by a variety of issues like airway obstruction, respiratory fatigue, or disease. Signs of inadequate respiration include either tachypnea, fast breathing, or bradypnea, slow breathing, especially if the rate is outside the normal range, may indicate inadequate ventilation. If the patient is using muscles in their neck, chest, or abdomen to breathe, it indicates they are struggling to get enough air. If the breaths are very shallow, meaning there is little chest movement, it suggests that the body isn't getting enough air. Look for signs of obstruction or fluid in the airways, such as stridor, wheezing, or gurgling sounds, which indicate respiratory distress. A bluish color around the lips, face, or extremities signals hypoxia, lack of oxygen, and indicates that the patient isn't breathing adequately. If the patient is confused, lethargic, or unresponsive, it could be a sign of inadequate oxygenation. To further assess the adequacy of oxygenation, EMTs use pulse oximetry, a non-invasive tool that measures the oxygen saturation of hemoglobin in the blood. Attach the pulse oximeter to the patient's finger, earlobe, or toe. The device will give you a percentage reading of oxygen saturation, SpO2. A normal reading is typically between 95 to 100%. If the reading falls below 90%, this indicates hypoxemia, or low blood oxygen, and requires immediate intervention. Pulse oximetry can help guide your decision-making. If the patient's SpO2 is low, you'll need to provide supplemental oxygen to improve oxygen levels and address any underlying causes of respiratory distress.
In an EMT setting, assessing and maintaining a patient's airway is one of the most important steps in patient care. A compromised airway can quickly lead to respiratory failure and can be life-threatening. Understanding how to assess the airway and perform the necessary interventions ensures that you can help keep the airway clear and the patient breathing. Start by determining whether the patient's airway is open or obstructed. Look, listen, and feel for signs of breathing. Look for chest rise and fall, indicating that air is moving in and out of the lungs. Listen for breath sounds, such as normal breathing, or if there are any abnormal sounds like wheezing, gurgling, or snoring. Feel for breath by placing your cheek near the patient's mouth and nose to check for airflow. If the patient is not breathing or has a blocked airway, you must intervene immediately to ensure the airway is open. For most patients without suspected spinal injury, the head tilt, chin lift maneuver is used to open the airway. Place one hand on the patient's forehead and gently tilt their head back. Use your other hand to lift the chin upward, which helps pull the tongue forward and open the airway. This maneuver is effective for most patients and allows air to flow freely into the lungs. This technique should be used cautiously in patients with a suspected spinal injury, as tilting the head could cause further injury. For patients with a suspected spinal injury, you should avoid the head tilt, chin lift maneuver. Instead, use the jaw thrust maneuver to open the airway without moving the neck. Position yourself at the patient's head. Place your fingers behind the angle of the patient's lower jaw and gently lift the jaw upward. This technique moves the jaw forward, helping to clear the airway without manipulating the neck. The jaw thrust maneuver is essential when spinal injury is suspected, as it minimizes the risk of further damage to the spine. The oropharyngeal airway, OPA, is used in unconscious patients who do not have a gag reflex. It helps keep the tongue from blocking the airway. Measure the OPA by placing it next to the patient's face to ensure proper size, from the corner of the mouth to the earlobe. Open the patient's mouth using the cross-finger technique. Place your thumb and index finger on the top and bottom of the mouth and gently open it. Insert the OPA upside down, with the curved part facing the roof of the mouth. Once the tip reaches the back of the throat, rotate the OPA 180 degrees to position it properly. If the patient begins to gag, remove the OPA immediately, as they may have an intact gag reflex. The nasopharyngeal airway, NPA, is used in patients who are semi-conscious or have an intact gag reflex. It is also preferred if the patient's mouth is injured or cannot be opened. Select the appropriate size NPA by measuring it from the tip of the patient's nose to the earlobe. Lubricate the NPA with a water-based lubricant for easy insertion. Gently insert the NPA into the larger right nostril with the bevel facing the septum, the wall between the nostrils. Slide the NPA into the nasal passage, following the natural curve of the airway. Once inserted, check to ensure the NPA is not causing any discomfort or obstruction, and that the patient is breathing easily. Proper airway management is crucial for ensuring adequate oxygenation in a patient. By assessing the airway and using techniques like the head tilt, chin lift, or jaw thrust maneuvers, and inserting either an OPA or NPA when needed, you can help maintain an open airway and provide life-saving ventilation. Always monitor the patient for signs of further airway compromise and be prepared to intervene as necessary.